This short video is about my experience with Decadron, dexamethasone, since 2010 involving over 1,000 patients and family for dental and non-dental acute pain. Yes, I'm a general dentist, but I'm also a dental anesthesiologist. Back in 1983, while I was an anesthesia resident, part of my training was acute pain management after surgery. As with all programs live and recorded, I need to declare if I have any financial interest in the material presented. I can honestly say there are no financial conflicts, but if you do watch it to the end, like or subscribe to this YouTube video and I'll earn a penny. Participants should be cautioned about the potential risks of using limited knowledge when integrating new techniques. So let me ask you this. Do you feel inflammation is responsible for acute pain? Is it A, I just want to get through this video, B, absolutely, C, maybe a little, or D, ask me again after the next few slides? Although my personal journey with glucocorticosteroids started in 2010, it was in 2014 that it became obvious to me that NSAIDs have some serious and possibly lethal side effects and are not recommended or tolerated by some patients. So I actually sent off an email to Dr. Kusin, and then about 3 days later, my receptionist walked into my operatory and said, "Who'd you piss off at the FDA?" So I picked up the phone, and one of the representatives from the FDA asked me and said, "We've just had a meeting over your email. We want to know if that was a rhetorical question you really want to know." I said to the representative, "I really want to know how bad it is to take NSAIDs. Right now, the New York State and many states are recommending NSAIDs combined with acetaminophen to treat acute dental pain. And if there are some serious side effects, I want to know how real it is. So how real is it?" And the FDA came back saying, "We don't know. We will never know, but it's real. And if we had the opportunity, we probably would take it off the market." Recently, more information is confirming NSAIDs aren't for everybody. Here's an article that said common painkiller linked to heart failure in patients with diabetes. So clearly NSAIDs are not for everybody. Even our healthy younger patients are experiencing some side effects. I know from presenting this topic that a few providers and patients will never change. I hope you have an open mind and, like me, are thinking outside the box. Here's a colleague that called me up after being stung by a wasp. He called me up and said, "I was just stung by a wasp. My hand is turning bright red and I'm having a lot of pain. What should I do?" I suggested she take 8 milligrams of dexamethasone. She responded, "I don't take any medication." So we settled on 4 milligrams of dexamethasone. Then approximately 30 minutes later, you can see that the swelling is gone. And I asked her, "How's the pain?" She said, "The pain is gone." Like how far I can tell you firsthand that once the inflammation is gone, the results can last from days to months. I recently received a steroid injection in my knee right after Thanksgiving. Prior to that injection, my pain was at a level 7 while walking, and periodically a 7 while driving, to the point where I needed to set the intelligent cruise control even for short trips. And it was completely gone on day 2, and it's now the end of January and still I'm pain-free. My knee injection confirmed the absolute value in using the injectable form of Decadron. Here is a 12-year-old patient that removed C and H with exposure of 6 and 11. This case compares the laser to a scalpel and the minimal amount of swelling, if any. For this young patient, I injected 2 milligrams of dexamethasone over the apex of number 6, and then another 2 milligrams of dexamethasone over the apex of number 11. Before I let her leave the office, I gave her 600 milligrams of ibuprofen, and this is a follow-up the following day. The patient was told to go to the orthodontist a week later, and when I did my post-op call the next day, she sent me this cell phone picture showing that she'd already been wired up and there's virtually no swelling or inflammation. If you look at the right side, the number 6 side, which was done with the laser, there's great healing, but compared to the scalpel on the left side, you really can't tell them apart. Here's another patient 24 hours after working on a heater and there was a flashback. So he went to a doc in the box, also referred to as an urgent care center. Since he looks like a terrorist and a druggie, he was given instructions for Motrin and Tylenol. But because the pain was so intense and it really looked nasty, I brought him to my office and gave him 4 milligrams of Decadron. And from that day on, I now keep it in my computer bag. Here he is about 18 hours later, and I asked how the pain was. He said the pain was gone in about an hour. Another great clinical case showing how dramatically it helps healing. So here's my receptionist. On the far left side is her shin after being on antibiotics for 2 weeks after a shin injury. She said to me, "I'm in a lot of pain and I'm on antibiotics, but I don't think it's getting any better." I said, "Take this 4 milligram dexamethasone pill and then called me in the morning. So the following day, which is a little over 12 hours later, that's the middle picture that you can see, and there's been traumatic healing. She then took another 4 milligram pill for a total dose of 8 milligrams, and the third picture on the far right shows it at about 36 hours later. This is a neighbor of mine who called me up one day and said, I am having these really sores and blisters all over my mouth. He had gone to a doc in the box, also known as an urgent care center, and they placed him on an oral rinse and nothing was helping. So I put him on 8 milligrams of dexamethasone the first day. I told him to take 8 milligrams of Decadron the second day, and then go to 4 milligrams on the third day. So he had a total dose of 20 milligrams. On the far left, you can see after the infection was about 2 days old, and that's when he first called me and sent me the photograph. And then the photograph on the right is his tongue after 3 days of dexamethasone. When I asked him how the pain was, he said the pain was virtually gone within a few hours after the first dose of the dexamethasone. A lot of our older patients can't tolerate an NSAID or acetaminophen because of their liver functions or possibly a blood thinner. So here's an older patient who's on a blood thinner. I had to remove 22 to 27 along with an alveoplasty. This is a photograph of him 24 hours after treatment. Here's the intraoral view, and you can see that there's a lot of bruising from the blood thinner, but there's no significant swelling. Here's another photograph of this gentleman 48 hours later. You can still see that the bruising is significant and probably worse, but intraorally there's no swelling and the denture fit really well. For the first 20 plus years of my practice, I always was taught to go through the top of the tooth and section it to 3 places to preserve the buccal plate. Since taking Dan Popper's oral surgery course, I now go through the buccal. I make a buccal groove, snap off the clinical crown, and then I make my Y pattern to section the roots into 3 separate roots. When I section, it preserves the buccal plate and it limits the size of my flap. I was taught that the pain is from the periosteum, and the injection of Decadron must be in the soft tissue adjacent to the procedure. Think back to your own personal way of managing inflammation. So what does NSAIDs imply? Just the name makes you wonder if steroids are better, but it's much simpler to go buy Motrin over the counter than go visit the doctor or have a prescription filled. I'll bet most of you have taken a Medrol dose pack. And when you see the relative anti-inflammatory effect is 4, the Decadron is actually 30. Probably the main reason I routinely use Decadron is the half-life is 36 to 54 hours. It was made for dentistry, and the pain from acute inflammation also because the half-life, it doesn't have to be tapered over time. I received testimonials from attendees of my opioid and MADAC training programs, and when I first glanced at this one, I immediately called my brother to transfer all my assets. Then I actually read the email. This doctor also sent me 3 other identical cases involving sick patients that he would not be able to give NSAIDs or Tylenol to. Here's another case of a participant who took my program. His wife received laser therapy and was in a lot of pain. She called the dermatologist. The dermatologist said, absolutely not, just stick with the Advil. When she asked her husband about the dexamethasone, he called me up and said, would it be a better drug than just suffering? And I said, absolutely. So the wife took the dexamethasone for approximately 3 days and did exceptionally well. New York State requires all prescribers to take a course that involves end of life. So I found this and obtained permission to use it from the University of Buffalo School of Pharmacy, and this pulls it all together.
Metastatic bone pain, and where the World Health Organization ladder may not be as effective. So it's important to remember that adding either NSAIDs or COX-2 inhibitors or steroids are an appropriate treatment for metastatic bone pain. And they can be opioid sparing. Because we get at the root of the pain by using these anti-inflammatories, we can often use less opioid. So with the NSAIDs and COX-2 inhibitors, they are often useful for that mild to moderate pain and are adjunctive, as I stated. Unfortunately, though, they do have a ceiling effect. At some point, no matter how high you go with the dose, you're not going to get any more effect out of it. And especially in the elderly patients, toxicities including GI, renal, and cardiac become an issue in the use of these medications. To talk about corticosteroids, they tend to be anti-inflammatory and are in many cases, the drug of choice is dexamethasone because of its high potency, with a range of anywhere between 2 and 16 milligrams a day to start. with use up to 30 milligrams a day, and there's even reports using up to 100 milligrams a day. Additionally, corticosteroids have the effect of being antiemetic, appetite stimulating, antidepressant effects more in the stimulatory nature. The patients feel very activated when taking these, and that's often a part of their condition, is that they feel very sedated, very lethargic, and it gives them a stimulated feeling. And then one of the last things to consider about corticosteroids is that, yes, we know that there's some side effects associated with them, but most of them are long-term. And unfortunately for our patients in hospice, those long-term side effects will never manifest because often the patients are deceased before they come around.
About 3 years ago, I ran into my neighbor Rob, who was dressed like the mummy. I said to Rob, I said, "What happened to you dressed like the mummy?" He said, "I was working in the backyard and there was a lot of poison ivy and I got covered in poison ivy, so I'm wrapped up." I asked him if he liked one of my magic pills and he said, "Absolutely not." Then about 20 minutes later, my doorbell rings and he took 4 milligrams of dexamethasone. And I called him up and I said, "How you feeling?" And he said, "I felt like it never happened." Recently, I ran into Rob again and he's been dressed up like the mummy again. I said, "What happened?" He says, "I got poison ivy again." I said, "Would you like one of my pills?" He says, "No, I'll manage." And then sure enough, he reaches out to me and he said, "Can I have one of those pills?" And I said, "I keep it with me now since my incident with the burn victim, and I keep it with me. So now I'll be able to drop it off around 9 o'clock." So I dropped off the dexamethasone to him. I called him up the next day. "How are you feeling?" And he said, "I slept like a baby." I'm not the only one recommending steroids. I'm just trying to show you the drug and how I use it. When I once asked an oral surgeon if he used Decadron, his answer was, "I only use it on my big cases." So I looked at him and I said, "Isn't every case a big case?" Many participants tell me that they're using Decadron, and since using Decadron, it's been their best practice builder. So when I first started using a glucocorticosteroid, the drug that I was using originally was Solumedrol. So here's a patient that was my first patient that I was using a steroid on. I needed to remove 1, 16, 17, and 32. Now, typically, this patient would be very swollen, have limited opening, and a significant amount of pain. So what I did is after doing the surgery, I placed 20 milligrams of Solumedrol on the number 17 area, and I put 20 milligrams adjacent to number 32. Here he is a week later. There's virtually no swelling and there's no limited opening. When I asked him how he was feeling, this is his response.
So how was your treatment?
It was great.
How much pain did you have afterwards?
Um, it wasn't too bad. It was more discomfort.
Okay, and you're really not that swollen, so that's super.
So the submucosal injections of dexamethasone is getting a lot of traction, and it seems to be very effective in treating acute pain.
Patients will experience edema typically for 7 to 10 days, which can be minimized with an intraoperative IV dose of 8 milligrams dexamethasone.
So here is a friend of mine who's a chronic pain patient who's on a fentanyl patch. And then he called me up on the weekend and said, "I'm having a lot of pain in my lower left molar. Can you see me on Monday?" I said, "I'll work you in today." And I managed to surgically remove tooth number 18, sutured up the flap, and I gave him 4 milligrams of dexamethasone in the soft tissue adjacent to the extraction. When I called him up the next day, realizing that he's on a fentanyl patch with his back pain, I called him up and said, "How you doing?" He said, "I'm doing great. I have no pain and I have no bleeding." Here's my nephew. I took out his 4 wisdom teeth. I gave him 2 milligrams of dexamethasone in the number 17 area. I gave him 2 milligrams of dexamethasone as an infiltration subcutaneously adjacent to number 32. And when I called him up the next day, I asked him how he's feeling. He said, "I've just taken 200 milligrams of one Advil, and that's all I needed." I'm sure many of you watching and up to this point want to know, how do I purchase and how do I use it? I buy the supersized bottles by the case. That's a 30 ml bottle that contains 4 milligrams per ml. I draw up 1 cc or 1 ml in a small tuberculin syringe, or the typical syringe that you'd see a diabetic use, and they only hold 1 cc or 1 ml. I then inject it into the soft tissue adjacent to the area that I'm working in. That dose is 4 milligrams because the syringe only holds 4 milligrams. Here is a young patient in his early 20s. This photograph was taken immediately after the surgery where I deposited 8 milligrams totally. I put 4 milligrams of dexamethasone, a few drops over the apex of every tooth in the upper right quadrant, and then another 4 milligrams over the apical area of every tooth on the
How do you
upper left
feel?
quadrant.
Not bad.
On a scale of 1 to 10, how's the pain?
0.
That's really good. How much have you taken for the pain so far?
Nothing.
Just the Advil I gave you that day and then the one I just gave you a couple minutes ago.
Yep.
That's super. Thank you.
So because he was a younger patient, he got the dexamethasone as an injection. I gave him 800 milligrams of ibuprofen in combination with that because they work by a different mechanism prior to leaving the office, and he did very well. This is 24 hours post-op. This is the intraoral view that you see 24 hours later. There's just no swelling, and the ADA Practical Guide to Substance Use Disorder. Why they don't go into deeper or greater detail, I don't know. Take a moment to read about the glucocorticosteroids. This may be easy to read. Swelling following surgical procedure would similarly be expected to lessen by the preoperative NSAIDs such as ibuprofen. However, the anti-inflammatory effects of preoperative ibuprofen are modest at best. When surgery expected to produce significant swelling, a short-term therapeutic regimen of an anti-inflammatory steroid is recommended. Glucocorticosteroids appear to inhibit all phases of inflammation. They block the increased capillary permeability produced by histamine and kinins, and therefore decrease edema. Capillary dilation and migration of the leukocytes and phagocytes are all decreased. And they just work by a different mechanism. The ibuprofen works on the COX-2 enzyme, reducing the prostaglandins, and this works on a cellular level. So in combination, they really do give you exceptional results. When my daughter was about to have a C-section to deliver her twins, I asked her to talk to her obstetrician about giving her dexamethasone injected into the surgical site. And he wouldn't hear about it, but I went and I looked up some literature, and it turns out when you use dexamethasone, it really does make a difference in the amount of pain following a surgical or a C-section. You know, in the past I used to Google things, but now I've started to use ChatGPT. I find that ChatGPT seems to give me a more appropriate answer. So when I Googled what glucocorticosteroids are commonly injected into the knee, this is what I got as a result. In conclusion to this orthopedic study, the study following total knee replacement is 2 doses of dexamethasone reduced morphine consumption during the first 48 hours after total knee replacement. Here's a conclusion from anesthesiology. We recommend dexamethasone 4 to 8 milligrams for the prophylaxis and treatment of postoperative nausea and vomiting. The higher doses produce an antiemetic effect benefit for up to 72 hours. A dose of 8 milligrams intravenously provides an analgesic benefit. After treating John, who's a type 1 diabetic with an IV of D5W, and then placing 4 milligrams of dexamethasone after tooth extraction, he emailed me that night saying that he's having a lot of trouble keeping his glucose below 300. When I spoke to John the following day, I said, "How are you managing?" He said, "I'm doing great. I'm having no pain, but I'm just not comfortable where my glucose went to about 300. Then a few weeks later, he comes to me and shows me his new Libre system. And here I'm looking at his Libre monitor, and it's showing that he's at 98. I said, "John, how'd you get to almost 250? He says, "Well, I had a half a bowl of oatmeal at 8 o'clock in the morning, and by 10 o'clock in the morning, it's now at 250. As we enter the 7th year of mandatory training, several questions have always come up at the conclusion of the program. So here's a few of the frequently asked questions. Many providers are familiar and comfortable with prednisone and the Medrol dose pack, some for prescribing the medication, and others from personal use. The question is, do you need to taper Decadron or dexamethasone like we do prednisolone or the Medrol dose pack? And the answer is no. Since the drug has a half-life of 36 to 54 hours, it tapers itself. Another frequent question is, what are your indications for using the protocol, and what are your contraindications for that medication class? And my answer is I pretty much use Decadron on everyone in all age groups with and without complicated medical histories. I may use NSAIDs in the Tylenol combination in addition with my young healthy patients since they work differently and have different mechanisms. Everyone should be aware of the contraindications. The only contraindications are patients who have had an allergic reaction or serious side effects from previously taking glucocorticosteroids. An example may be hiccups, or after taking a Medrol dose pack, they had a complication they weren't. Here is my current protocol, and I would suggest that you take a screenshot of it. Whenever possible, I'll give them 4 milligrams at lunch the day before. Then I'll give them 4 milligrams as a subcutaneous injection adjacent to the site. I'll max out at 8 milligrams with 2 sites when I use the medication as an injectable. Then I'll send them home with 2 4 milligram pills, and I will follow up in the morning with a phone call. If they're doing well, they take nothing. If they have slight pain, I tell them to take a half a pill. And if they're still really uncomfortable, I have them take another 4 milligram pill and then follow up with the conversation the following day with the same protocol. Every day I get a few text messages, and here are just a few of the testimonials that I receive. I would like you to keep in touch with me, especially if you're using dexamethasone. I'd like to know what your experiences are, good or bad. This is Jeffrey, and he comes back to me and he says, I'm getting back to you with my report on my response to dexamethasone. Within an hour, my facial pain was gone after receiving 4 milligrams of dexamethasone, and I still continue to do well. Here's another participant who's used it on 6 patients ranging in age from 11 to 93 and thanking me for introducing them to dexamethasone. This short video is about my experience with Decadron or dexamethasone since 2010, involving over 1,000 patients and family for dental and non-dental acute pain.
Have a great day today and every day.